Director of Columbia's Center for Clinical Medical Ethics. We are so grateful for you to join us for the inaugural Lisio Family Lecture, endowed by Dr. Arnold Lisio and his wife, Dr. Ann Moore. And the goal of this lecture is to bring nationally renowned speakers to Columbia University Irving Medical Center to address important ethical issues at the core of medical practice. The Lisio family's vision is that this lectureship contribute to the ethical formation of medical students and to the flourishing of the doctor-patient relationship. An internist, Dr. Lisio came to Columbia in 1961 and led an active clinical practice until his retirement in 2015. Dr. Moore is a 1969 graduate of Columbia College of Physicians and Surgeons. She is a practicing medical oncologist on the faculty at Cornell Medicine. Without further delay, let me introduce tonight's speaker, my friend, Dr. Farr Curlin. Dr. Curlin is the Josiah Trent Professor of Medical Humanities in the Trent Center for Bioethics, Humanities, and the History of Medicine, and he is co-director of the Theology, Medicine, and Culture Initiative at Duke Divinity School. Before moving to Duke in 2014, he founded and was co-director of the Program on Medicine and Religion at the University of Chicago. At Duke, Farr practices palliative medicine and works with colleagues in the Trent Center, as well as in the Divinity School, to develop opportunities for education and scholarship at the intersection of theology, medicine, and culture. He's interested in the moral and spiritual dimensions of medical practice, particularly the doctor-patient relationship, the moral and professional formation of physicians, and practices of care for patients at the end of life. Tonight's talk is titled Mere Healers: What Medical Training is For and Why It Matters. And Dr. Curlin has just released a brand new book titled The Way of Medicine, which we will provide a link to in the chat. This evening, we will hear from Dr. Curlin for about 30 minutes, and then we'll have plenty of time for Q&A. Please feel free to add your questions to the chat function, and after Dr. Curlin's formal remarks, I will help moderate those questions. And I also invite those of you, we have a small group here in the room. There's pencils and paper on the table, and if you would like to pass me questions during the Q&A, I'm happy to give those questions to Dr. Curlin as well. And additionally, if you'd like to join our listserv, we'll provide information for that in the chat feature as well. So without any further delay, I'm going to turn it over to Dr. Farr Curlin. Thanks so much, Farr, for being here.
Thank you, Lydia. It's a pleasure. It's not as much of a pleasure as it would be were I able to be in your presence there physically, but I am grateful for this opportunity to speak with you and the folks that are gathered there virtually at Columbia. I certainly thank Dr. Lisio and Dr. Moore for this remarkable new series, and certainly share that desire that this talk and future talks contribute to the ethical practice and the moral formation of future clinicians. So it's really an honor to be with you, and I hope to be with you in person before long. 9 years ago, Don Berwick, who many people may recall served as director of the Center for Medicaid and Medicare Services under President Obama, gave a commencement speech at Harvard Medical School. And that speech went viral. It was spread across emails throughout academic medicine in the United States, and including the University of Chicago, where it entered my inbox, accompanied by enthusiastic compliments from a number of my colleagues. In his speech, Berwick told of a former patient named Isaiah, a young Black man living in poverty who suffered and survived acute leukemia, but went on to die from complications both of his illness and of the poverty he suffered. With Isaiah's story as background, Berwick told the Harvard medical students that they had two duties. First, to cure the leukemia. They have a duty to bring the benefits of biomedical science to their patients. But, Berwick added, they must do more. They also have a duty to cure the injustice that afflicted Isaiah, to fight against poverty, for a stronger social safety net, and for policies that regard healthcare as a human right. Berwick's speech struck a chord. It reflected a widespread sense that medical educators must prepare students not only to, in Berwick's terms, bring the benefits of biomedical science to bear, but also to contend for a more just political order. It's not enough, it seems, for physicians to merely attend to those who are sick. When I read Berwick's speech, it struck me as a logical extension of a decades-long series of calls for medical educators to do more, to raise the bar for what success looks like with respect to medical training. Indeed, it seems to me the field of medical education has remained in perpetual ferment, with new moral movements bubbling up every few years, one giving way to the next. From biopsychosocial medicine to patient-centered medicine, to shared decision-making, to holistic medicine, to integrative medicine, to narrative medicine, to culturally competent medicine, to medical professionalism, to character in medicine, even spirituality in medicine. And Berwick's his call for students to use their professional voices, as he put it, to push for more just legislation, took this series one step further. And that, I will say, has been taken up, that call, by medical educators in many schools, encouraging students to develop their skills as political advocates. But this evening, I propose to you that these moral movements in medicine, while commendable, each of them, commendable in many respects, both are symptoms of and paradoxically contribute to the deeper problem to which they respond, namely the demoralization of medicine itself. I'll propose that to escape this cycle of demoralization, medical educators will need to return to a more modest vision for medicine, in which medical education has succeeded if it trains mere healers, practitioners who reliably show up and attend to those who are sick in all of their human complexity, and skillfully and conscientiously seek to preserve and restore their health. That healing work is not everything, but it is good. And it is, I will argue, what makes medicine the practice it is. A practice that's good enough to motivate and inspire physicians throughout their careers. Though diverse, the various moral movements in medicine that I listed respond to a generalizable problem, namely that clinicians, even if scientifically informed and technically proficient, do not reliably respond to their patients in ways that do justice to those patients. It seems that as medical practitioners wield more and more scientific knowledge and technical power, they are perpetually prone to ignoring patients' humanity, to treating patients as widgets or worse. And these behaviors, while condemned consistently in the explicit medical curriculum, are nevertheless taught infallibly through the implicit or hidden curriculum, in which trainees learn to value moving patients efficiently through the system in ways that are responsive to the needs of that system, and to doing their best to keep their heads down and protect themselves in the process. Trainees experience themselves as becoming personally corrupted by patterns in which they are complicit, and yet they feel powerless to change. And in their diverse responses to this general problem, the various moral movements in medicine seek to recover and shore up humanistic values. Medical educators emphasize that they are not merely going to teach the science, but also the art of medicine, where the latter includes words like humanism, holism, culture, compassion, and, as suggested by Berwick's speech, social consciousness and political advocacy. Although these movements, again, are well-intentioned and generally espouse values that, at least in the abstract, all can affirm, they nevertheless seem to me symptoms of the problem to which they respond. And by masking or palliating the root of palliative is to cover, by palliating that problem, I think they may get in the way of the very severe therapy that the profession of medicine and its educators needs. The problem of which they're symptoms and to which they respond is the demoralization of medicine itself. The loss of public and professional clarity and confidence about how and why practicing medicine is good. Again, good enough to merit the devotion of practitioners throughout their adult lives. Now, to speak of medicine being demoralized presumes medicine was once moralized. And by moralized, I mean simply that medicine was understood as a practice that aims at something good, uncontroversially good, and that the goodness of medicine's purpose could be taken for granted by those who aspired to join the profession's ranks. In just this sense, it seems to me, medicine has long been moralized, even when it had little technical power to cure illnesses like Isaiah's leukemia. For ages, it was taken for granted that the purpose of medicine is the patient's health. Aristotle, whose father was a physician, wrote, quote, "Now, since there are many actions, arts, and sciences, their ends also are many. The end of the medical art is health, that of shipbuilding, a vessel, that of strategy, victory, that of economics, wealth." So Aristotle took these claims as starting points for further reasoning. These are things that are known immediately by both the many and the wise. And in the past few weeks, I personally have been reading Plato's Republic for the first time in decades. And I'm struck by how often Socrates and his interlocutors used the obviousness of what medicine is for, what doctors are for, as a starting point to understand more difficult questions that they were trying to get clarity about, such as what justice is and what justice requires and what a ruler is for. That the purpose of medicine is healing, that healing is good, seems to be something they could take for granted. But over the past few centuries, and particularly in the past 2 generations, something has changed. One change is so familiar it hardly needs stating. That is that the rise of modern scientific medicine, which has brought unspeakable benefits, has also brought a tendency toward scientific reductionism, toward reducing the patient to her illness and the illness to its mechanisms, all of which are known with the cool rationality of biology. And it was that tendency that George Engel critiqued in his famous call for in the late 1970s for a biopsychosocial model of illness. It's equally familiar to those practicing medicine today that medicine is increasingly governed as a large bureaucratic industry in which both patients and clinicians feel themselves moved along as widgets and cogs in a wheel. But there's another change that is less familiar perhaps, or less obvious perhaps, but equally consequential. And that is a profound change in public and professional understandings of what medicine is for. As noted in traditional understanding, medicine is for the patient's health, where health is an objective characteristic of the human body. What Leon Kass has called, in a definition that seems to me as good as any put forward, the well-working of the organism as a whole. That understanding of medicine as oriented to health has not disappeared, and it still makes sense of much of what physicians do, but a rival understanding has come to have increasing influence, particularly in the last 2 generations. In that rival understanding, medicine is not merely for health, which seems too narrow and limited, but it's also for well-being, a broader and more subjective norm than health, and one which ultimately only the patient can discern, insofar as only the patient can say what is good for him. Expanding the goals of medicine from the patient's health to the patient's well-being fits the pattern of expanding our vision of what medical trainees should do. that they must be more than mere healers. And for decades, medical educators have trained students to think of themselves this way. That is, to think of themselves not merely as practitioners pursuing the patient's health, objectively considered, but instead as providers offering patients diverse services that patients can use to pursue their own sense of well-being. The problem, however, is that by shifting from pursuit of an objective norm that all regard as good, namely human health, to a subjective norm about which only the patient can have expertise and which may include interventions and outcomes that the physician does not recognize as good, namely this patient well-being, we necessarily come to demoralize medicine, to convert the physician from a healer to a provider of services. And this demoralization then leads to detachment. In what my colleague, moral detachment that is, and what my colleague Chris Tollefson and I call the provider of services model in our book that Lydia mentioned, The Way of Medicine, Ethics in the Healing Profession. In the provider of services model, medicine has given up even the pretense of pursuing something genuinely and objectively good, something that all can recognize as good and can hold us accountable across our various disagreements. The physician rather understands herself in the provider of services model as giving scientifically accurate information and offering technically proficient services, but withholding judgment about whether the end to which these services will be put is in fact good. That is for the patient to decide. To presume to know what is good for a patient has come to seem in our time a form of presumption, of letting idiosyncratic and biased personal values interfere with a properly detached professional scientific posture. Yet, insofar as physicians give up making judgments about what they should pursue as physicians, they detach from their work as physicians, not least because the work is no longer obviously and intrinsically good. And not being good, it doesn't seem to be worth the effort. It's not sufficiently rewarding. Students and clinicians may continue to go through the motions of practicing medicine efficiently and effectively, checking the boxes that medicine as industry trains and incentivizes them to check. But something inside them dies in this process. And so we see an epidemic of physician burnout, an epidemic that reaches all the way down to medical students, among whom, by the end of their clerkships, about half meet criteria for burnout. And what do students and clinicians who are demoralized and burned out do? They grow cynical and self-protective. They keep their work at arm's length, morally speaking, protecting themselves from putting too much of themselves, too much of their identity into their work, and too much of their effort into an exhausting activity that does not seem particularly good. And as a result, they tend to treat patients with less care and human concern than patients need and deserve. They recapitulate, that is, the very patterns of behavior that lead medical educators to attempt yet another round of reform. But these rounds of reform never succeed. And they cannot succeed, if my diagnosis is correct, because they leave the provider of services model unchallenged. So rather than insisting that medicine is for the patient's health, that the patient's health is, although complex and difficult to discern sometimes on the margins, is an objective reality that is intrinsically good and which physicians can joyfully pursue with all of their personal and professional might. Instead of that, they accept the demoralized cake of providing healthcare services, and then they try to add various layers of moral icing by invoking terms like humanism and professionalism. And strangely, it seems to me, these terms are invoked less to challenge the provider of services model than to reify it. Educators frequently talk as if being patient-centered and humanistic and professional means being fully committed to providing what patients say they want, regardless of whether the physician believes doing so is consistent with their commitment to healing, to the patient's health. Now, several decades into this process, several decades at least, I observe that medical students often are confident that they can see through and critique medicine's shortcomings, its various failures to do more than merely seek healing for those who are sick. Indeed, I was recently contacted by an earnest pre-medical student at a large university who has started an organization to reform medicine. And he spoke with what was to me striking moral certitude about how physicians have failed to do enough to change social policies. That kind of certitude I find quite common among students. Yet, despite being certain they can see through medicine's failings, I find students are often characteristically agnostic and inarticulate about what it means to be a physician, except to be committed to a more just society and to honoring what patients say is important to them. I find it like pulling teeth to get students to imagine anything a patient or supervisor might ask them to do that they would refuse on the basis of their professional commitments. In addition, trainees are deeply attentive today, and I would argue this is true because we have trained them to be attentive to how medicine threatens both them and their patients. With respect to the threat to themselves, having been encouraged to separate their personal and professional identities, they think now a lot about work-life balance. They choose specialties that protect them from medicine, from interactions with patients, particularly time-intensive interactions with patients. And I think this is key, they are often restless to find something outside of medicine that's worthwhile that they can commit themselves to. Their exemplars are those who are making a difference in the world, not necessarily those who are merely healing, merely caring well for those who are sick one at a time. It seems to me they have heard the message that Berwick was promoting. If you are merely a clinician, you aren't doing much, or you're only doing half of what you ought to be doing. And you're likely serving the corrupt system. You need to get outside of mere healing and change the world. Now, I propose, in contrast, that medical education take a very different tack. I propose that to do the more that is needed, medical educators should aim to do less. Specifically, they should take as the goal of medical education the formation of mere healers. Mere healers are those who reliably attend to those who are sick or whose health is threatened, seeking to preserve and restore their health skillfully, wisely, in ways that do justice to the full humanity of the patient and that respect the patient's authority to decline their proposals. This approach recognizes medicine as the kind of art that requires long practice through a focused apprenticeship, that one cannot learn what the patient's health requires and how to preserve and restore that health except through long experience under the tutelage of those who already know, likewise by experience. Much as playing the violin does not preclude being involved in other worthwhile activities, practicing medicine does not preclude being involved in other worthwhile activities, including political advocacy, and any number of other activities. But just as we reasonably judge a teacher of violin by how her students play, we reasonably judge medical educators by how their trainees attend to those who are sick, and specifically whether their trainees' practices are conducive to healing. This focus and sustained effort and singular commitment make possible the depth of knowledge and clinical wisdom and skill that is not possible if medical educators are trying to train physicians to do innumerable other things as well. It seems to me, that is, that medical educators should be willing to forego nurturing, for example, amateur activists, political activists, in order to focus on forming professional healers. This approach also responds to medical students longing to do good, that longing which brought them to the practice of medicine, that longing to join a profession that has long been esteemed as deserving honor. The expansion of medicine's aims to include most anything that a patient might see as necessary for his or her well-being has brought a number of controversial practices into medicine. Practices about which diverse moral communities disagree and have always disagreed. And I think it should be obvious in September of 2021 that there is no consensus about the right policies for healthcare financing or housing, much less about sexuality and identity and the meaning of suffering and disability. Yet, whether Jewish, Christian, Muslim, or other, religious or irreligious, disabled or able-bodied, politically conservative or politically progressive, all can and do embrace the goodness of attending to those who are sick and seeking to preserve and restore their health. This limited but substantive shared commitment facilitates trust in the medical profession. There still is broad consensus that it is good to have a profession of skilled healers to whom one can turn when sick or injured. I think this consensus has been displayed brightly in the COVID pandemic, where despite all of the debates and terrible trenchant disagreements and political division about every number of policies, there has been uniform appreciation for the healthcare practitioners who show up to care for the sick without respect to the sick's other characteristics. Moreover, by aiming at health, a genuine human good, physicians over time develop and exercise a genuine authority of expertise regarding how to respect and pursue this good. They pursue this good while respecting the patient's proper authority to give or withhold consent to any physician proposal. But note that in this vision, the physician is not just giving information, not just providing options, not focusing just on the means and letting the patient or a third party determine the ends. Rather, she's conscientiously contending in partnership with the patient, in partnership with her colleagues, with the system, insofar as possible, is contending for the patient's health, even sometimes against the patient's initial judgments about what they ought to do. That is a moralized, a morally charged endeavor. Now, before I close, let me say a word about why I'm both hopeful for the renewal of medicine and at the same time, I'm not optimistic. I'm hopeful because every time a medical practitioner comes face to face with a patient who is sick, they're confronted by the reality both that the patient exceeds all of their scientific categories, so that they're confronted by a reality that gives the lie to the tendency and the illusion, the tendency to take for granted that one can describe the patient in fully in scientific terms. And they're confronted with the reality that the patient needs more and less from them than the provision of healthcare services. The patient needs someone doggedly, conscientiously, persistently, winsomely, wisely committed to seeking their healing. And this encounter with reality, because people continue to get sick, this encounter with reality will not go away. And so it seems to me that provider of services model will never satisfy either patients or physicians. But at the same time, I'm not optimistic, at least in the short term, about the future of medical education and its efforts to renew medicine. And that is because to address the moral hole in the heart of medical education, educators have to be willing to critique and to detach from the provider of services model. And all manner of economic and social forces are aligned against them doing so. Within the massive bureaucratic industry that healthcare has become, there obviously are innumerable economic stakeholders and forces that are arrayed to preserve the status quo. We've seen that whenever there's been an effort at healthcare financing reform. In the system as it is, medical educators, if we're honest, have little power. And they're not actually running the hospital, running the system. And educators who actually challenge the economic arrangements of American medicine would likely soon, particularly in their own institution, would likely soon be replaced. I nowhere see medical educators calling out or challenging the major structures of contemporary healthcare as they're expressed in their own institutions. So for the foreseeable future, those who are employed by large academic medical centers like Columbia and Duke University, I think are not likely to disrupt the status quo in which clinicians are trained and managed into focusing on efficiency in the provision of healthcare services. And unfortunately, as I've noted, medical educators' various reform efforts, I fear, end up being a kind of palliation, not unlike health systems' efforts to provide massage and tickets to ice cream and meditation exercises and so on to deal with burnout. It's a kind of palliation that appears to do something, but actually does not address the underlying problem. That's on the economic side. And in terms of the social forces, my medical students' commitment to affirming their patients' wishes seems to me pretty culturally strong and deeply formed. Students are committed to insisting that only the patient can say what is right for them. I think that reflects a much deeper societal skepticism that's been building for centuries. The skepticism about there being any real good out there that we can reasonably know and pursue together, something that can hold two people across political lines mutually accountable. The philosopher Charles Taylor has famously described the modern era as one dominated by what he called the ethics of authenticity, where the task for each individual is to discern and enact their own unique identity, and to do so over and against the expectations handed down to them. Medicine gets caught up in this. It becomes an essential set of tools for enacting one's identity. Ours is a world of living your truth, not living according to the truth. And that I don't see changing anytime soon. In terms of a social barrier, the problem with training mere healers, those who can be relied on to attend to the patient's health, objectively construed, is that mere healers cannot be relied upon to provide any number of healthcare services, as they're called, that patients may believe are essential to their well-being, but which some physicians may believe contradict the patient's health. This becomes most obvious with respect to practices such as physician aid in dying. So physicians who merely heal, and if we commit ourselves to training physicians who merely heal, and that being enough, then we're going to expose further the controversies about practices of medicine that are not so obviously consistent with, and certainly not so obviously required by, a commitment to healing. And the reality is many people find this prospect threatening, including a number of leaders such as Ezekiel Emanuel, who a few years ago argued that such physicians, that is, physicians who refuse to provide legal services that patients believe are consistent with their well-being, should be driven out of the profession for letting their personal values interfere with their professional obligations to provide what patients seek. So I'm not particularly optimistic. But I'll close by going back to the patient that Dr. Berwick described, Isaiah. Although Dr. Berwick noted the fact that despite the extraordinary care that Isaiah received when he was sick with leukemia, which resulted ultimately not only the remission of his leukemia, but when it recurred 3 years later, a further cure through bone marrow transplant. He acknowledged that in the end, Isaiah still died of complex consequences of a very broken and unjustly ordered social system. It seems to me that although the physicians who cared for Isaiah did not change the world in the way that Berwick was calling on physicians to change the world, that it was and should be taken as enough by medical educators to train physicians who will take care of patients like Isaiah whenever they are sick, and with a full attention to all that they bring to their illness. That insofar as physicians aim to be patient-centered, to be socially conscious, to be holistic, to reduce disparities, to advocate for more health-promoting policy, all of that must run through and ultimately cannot displace the fundamental constitutive commitment of medicine, which is to preserve and restore the patient's health. And with that, I'll stop and would welcome your comments and questions.
Great. Thank you so much, Farr. That was excellent. I'm going to ask that people put questions in either the Q&A or the chat, either place, I'll find them. And Farr, there's a question from a medical student that I'd like to start with because I think it's excellent. And especially if there are medical students out there, let me know you're a student because we really want to prioritize hearing from the students and other medical educators as well. So here's the question. As a medical student, what steps would you suggest we take personally if we wanted to become clinicians focused on patient health as opposed to well-being? How can we be successful if we attempt to practice with the mere healer mentality against the broader headwinds you described?
Thanks. I'll selfishly promote the book again, so get a copy. But more seriously, I want to first of all say be encouraged to students who are thinking about this. Despite our deep polarization, despite the serious disagreements and deep controversies about what it is that physicians should understand themselves as being obligated to do as physicians, I have yet to find a thoughtful person in medicine, someone who wasn't just trying to be silly or make a joke, who doesn't recognize as a substantive, plausible, and reasonable claim that medicine is for the patient's health. And so I think you should be encouraged that if you commit yourself to acting in ways, only in ways that to the best of your knowledge are consistent with your commitment to the patient's health, you'll be able to explain that in few words in a way that people will be able to recognize. And that's the way I would approach it. Not setting out to persuade all of your teachers, certainly, or even your colleagues in advance that they need to agree with you that one practice or another is not required by a commitment to the patient's health, but instead commit yourself. And then when people ask you what you're doing, or you need to give an account for what you're doing or not doing, you just explain it. I'm committed to being a good physician. I'm committed to healing. And it seems to me that what's being asked of me here either contradicts that commitment or it seems beside the point with respect to that commitment.
Maybe just a follow-up from a medical educator. Health objectively constituted. Does this mean the same thing to every doctor and every patient? When we talk about medicine being oriented to health, how do we make sense of that?
The obvious answer is no. It doesn't mean the same thing to every doctor and every patient. But it clearly means something more objective and more tangible and concrete than well-being, as that term is used. And so health, it seems to me, is something that we recognize health in any living creature. We can tell when a tree is diseased. We can tell when a dog is diseased. We can't tell with perfect certainty. There's times where we're confused, and on the margins, we're not sure what is health and what is not. But we recognize this to be a feature, a characteristics of living beings, that when they are well working, healthy, that is to their good, and human health is to human good. Once we are committed to that, then of course we still are going to have many places where we're struggling together, much as Socrates and his interlocutors were struggling together to discern what justice requires. We're struggling to discern together what our commitment to health requires in a particular case. I think I've had many conversations with colleagues about this with respect to, for example, mental health. It seems to me mental health is an area where you often just cannot have the same kind of certainty about what is a sign of ill health versus a sign of something else. And yet the distinction is critical if we're not going to reduce mental health practitioners to just people trying to bring about desirable states of affairs. So health has got to be defined. If you read the book, it's defined in exhausting detail. I don't think exhausting, delightful detail. But it definitely needs to be defined further, and we have to reason together about that. And we can have disagreements, I think, on the margins, but health as a bodily characteristic of well-working is clearly more objective than well-being that might include, for example, asking the physician to cause your own death, because that for you is something you define as part of your well-being.
Thank you. So another question from another medical student. He says he agrees with your assessment and plan, to use a medical phrase, but he also says that a lot of his medical student peers would argue that this argument of yours is orthogonal to the real issue, which is the system. Idealism gets crushed by the system, which eventually burns out residents. Do you think this is true? And does the mere healers construct help improve this?
It's unquestionably true that the system crushes idealism. And it's a wonderfully put question, because the question asker is absolutely right that that the system has a power that can seem to overwhelm any of our aspirations, including the aspirations to heal. That being said, so this intervention I propose, this therapy I propose, it's necessary, but it's probably not sufficient. And yet, if we're going to think about reforming the system, I think we want to do that on the basis of a clarity about what medicine is, what it constitutively is for. And so that we can imagine how a system would function if it was a system conducive to medicine, one that facilitated medicine's purposes rather than hindering and interrupting and distracting away from medicine's purposes. So if you keep the provider of services model, that really fits hand in glove with a market mentality, with industry, with bureaucracy. And so the provider of services model, I think, has less teeth, if you will, to challenge the system as it is. But changing your vision and pursuing healing is still going to leave you in a broken system, trying to figure out how within that broken system you can act in such a way that is nevertheless health promoting, conducive to the patient's healing.
So maybe we can pivot slightly to pre-medical students, those who are interested in going into medical school. This is a question from a medical educator who thanks you for your thoughts and says these days pre-med students need to show a very broad portfolio in order to enter medical school, mostly in the sciences and diverse activities in other areas. Are we sending a message to students that we are selecting the non-healers?
Yes, I think we are, although to some extent. Though we are, this allows me to clarify or say more clearly something that's important here. By being mere healers, I don't mean mere bringers of biomedical interventions, as Berwick put it. A healer is not someone who merely brings the science and applies the technique. I mean, that it is right for medical education to react to and recoil from, and for patients to recoil from interactions that suggest that medicine can be reduced to applying scientific technique to manipulate the bodies, which are manipulated like machines of patients who are sick. Because to be sick is a human experience that is going to be different depending on all of your life. It requires skills and virtues of patience, of being able to listen, of being able to make discerning judgments in cooperation with a patient about which medical interventions for them, and given their vocation and given the goods that are available to them, which interventions are fitting and which are not. It's going to require virtues and capacities that are not going to be measured in your grades in chemistry and physics and biology. And so looking elsewhere as to how people are demonstrating that they have other human virtues, I think seems reasonable. But I do think what I want to caution against is looking for students who've been created a new organization or been advocates for something against something, as if we're always looking for the students who are breaking the boundaries. I think that's a problem, insofar as to be a physician is first to submit yourself under the boundaries of medicine and under the tutelage and training of people you give over your autonomy to, namely your teachers, to tell you what to do and what not to do, until you have embodied those practices long enough that you can discern with them which behaviors are fitting and not, including potentially coming to the point to say, hey, some of the things you taught me I don't think are as sufficient to medicine as what I propose. So that would be my caution.
So Farr, I'm gonna just take moderator's privilege, and maybe, I don't know if this is quite pushing back, but on the one hand, we want to select students who aren't necessarily boundary breaking, because we want them to, as you put it, to submit themselves to the structures of medicine, to learn well the craft, right? To learn the art well, to learn to become mere healers. And yet, at the same time, you've called out medical educators for not doing enough to essentially become activists who are challenging the power structures. Yeah. But yet you don't want activists, but yet you want them to become medical educators who are activists. So can you reconcile this for me, please?
Yeah, that's a good point, Lydia. To me, we are all called to be, as physicians, insofar as we're called to be activists, it's that activism which flows out of our commitment to healing, and is called for by and consistent with our posture and our practice of being committed to showing up and attending to those who are sick and seeking to preserve and restore their health. So sometimes that means standing up and being an activist. Sometimes it means going to the legislature. I don't want to suggest that students shouldn't be going to the legislature. It's just that I don't want them. What I see as the problem is almost because of the demoralization of medicine through the provider of services model. It's like people are casting about for something worthwhile, something more than just taking care of people who are sick. I mean, that just seems so minor. I need to do something big, change something out there. If you understand medicine rightly, then you will see that to attend to those who are sick and seek to preserve and restore their health is immensely valuable, sacred, worthwhile, difficult, challenging, stimulating work, the kind of work that can answer to the idea of a calling or vocation. But if you're just being a provider of services, it doesn't really evoke that kind of commitment. And so you find yourself wanting to go do something else to make a difference. That's the distinction I'm trying to make.
Can I ask one question?
Yeah, please. Alan is going to give us a question.
Okay, so I want to, following up what you said, I want to agree and disagree. Yeah, sure, a good friend of mine, he never really devoted his life to prison medicine. He never really saw that medicine itself was intrinsically good and worth devoting his life to that. So yeah, you're right about that. But there's another side to this. Ann Moore gave a talk not long ago when she talked about the heyday of the radical mastectomy. Now that was really a horrible, arrogant act that doctors committed for almost 100 years. And in the model of medicine that you were speaking about, the doctor imagined himself as healer. They were really abusing patients and women in particular. And so in order to discover that this treatment was an abuse of women, there had to be some kind of political critique of the arrogant doctor who knew everything. So today I had to speak with a woman who didn't wanted to save her breast and really needed a mastectomy. The longer story, I can't go into it, but that whole process, I was a bit of a provider of services there, but it was a negotiation with her in which I had to empathize with her and explain to her why a mastectomy really was the best treatment for her. So if I could get to the core of this, yes, to be a real healer, there is an element of deep critique one has to make of the practices that are common in medicine, the over-treatments that are going on constantly, the arrogance of physicians, the arrogance of institutions, of CEOs, of these huge corporate institutions in dominating medicine, medical care. You have to be an activist of sorts to really be a good doctor. So yeah, I agree with you, but I, at the same time, disagree.
Were you able to hear that, Farr?
I heard parts of it, and I'm not surprised that Alan agreed only in part. And that was well said, Alan. I'll just maybe clarify a couple of things. One, I'm certainly not advocating a return to the hubris of doctors thinking they know what's best for patients.
Good.
Except insofar as doctors do, I think, reasonably they do have authority of expertise to know often what the patient's health requires and what ways to pursue that health are likely to be more successful than others.
Not without talking to the patient and listening to the patient's side of things. You will never know what to do without engaging with the patient.
Yeah, so I'm not. If I seem to suggest that doctors can kind of do this on their own without engaging the patients, that's not what I intended to convey. As I said, doctors pursue the patient's health in a relationship, I would argue a relationship of solidarity and even friendship with patients, in which the common good they're pursuing is the patient's health. And the pursuit of that good is good for the physician. And the physician has to respect the patient's authority to say, I'm not pursuing it in the way you just proposed, period. And they're not going to understand the physician how to make recommendations often without listening to the patient and understanding where they're coming from. So I think I agree with you, maybe in whole.
Alan is satisfied.
Okay.
At least a comment. Any other questions from the room? Yeah, Dr. Joe Finn.
Hi, Farr. Thank you for your talk. I want to give you a different vision of a physician, and that's the public health physician. That's also part of our role. And I'm just wondering, you can go through your lives and you can, as a practitioner, and see how troubled the system is. You go through the pandemic here in New York last spring and see health disparities. And how could you not respond to that and because healing wasn't enough. You know, all that we did was not enough. To just be a healer was not enough. To rectify the inequities that savaged parts of our city was something that was a calling. And I think to go through that searing experience and not want to reform the system and bring health equity to healthcare is to be an abdication of our role as physicians. You know, we have a public health responsibility just as much as we have for the individual patient. I agree with you on the importance of the dyadic relationship. I agree with you probably on your views on assisted suicide. I agree that there are certain things physicians should not do that is outside the bounds of medicine. But I wouldn't dichotomize it and say, because I agree with all those other things in the microsphere, doesn't mean I can't act in the macrosphere. Because there are things that are external to the dyad that impinge on the dyad and make it impossible for us to heal.
So again, my claim is not that a doctor cannot act outside of mere healing. It's that to be a doctor and to have succeeded in medical training is to be characterized by mere healing, at least. That's the bar, it seems to me. And the challenge is, you're absolutely right. Mere healing is not enough to rectify all those terrible problems that resulted, not least in lots of people being sick and in illness distributing in ways that are not just. I'm not suggesting it's enough to rectify that. I'm suggesting that as a medical educator, if the people you trained showed up reliably, skillfully, consistently, and took care of any of those patients who are sick, not respecting their other characteristics, without respect to that, in a way, as Stanley Hauerwas puts it, that prescinds from other considerations, and through their efforts preserved and restored the patient's health insofar as is reasonably possible, that we should judge is a sign that medical education succeeded. Now, if you want to argue that every doctor must also be a skillful public health professional, I don't think we should do that, because I think that they are distinct things. They're not in conflict with each other necessarily, but they're distinct things, and you needn't have both to have one. But there are clearly doctors who do both and are good at both. That's not a problem. I just think the problem is when you try to suggest that you got to add being a public health advocate to being a doctor, you not only diffuse the focus of medical education in a way that gives the message to people learning to heal that that's not enough, that those people who showed up in the EDs, they didn't really do enough. It was the people out there on the governor's doorstep who really did what matters. I think that's a message that's not the message you're trying to point out, Joe. I'm not saying that's your message, but that's a message that I think people are getting across medical education.
Witness the gross inequities. If you witnessed it through your personal service, don't you have some moral obligation to act upon the inequities that you see? And
Yeah.
Really
Yes,
work?
I think so. You do have some. You do have some, but you also have to. I think you also have to recognize that insofar as you move at degrees of what's the word? Insofar as you further remove from the attending to the health of the one patient at a time, which is medicine, you also likely are getting into areas where there's less clarity and certainly less consensus about how to weigh different goods in the pursuit of different policies, for example. So, for example, let's say healthcare financing has enormous effects on people's health outcomes. And yet, I personally don't think there's a plausible claim that there is a clear medical consensus or a clear position on healthcare financing that follows as a virtue of good medical training, because different financing schemes weigh different values in different ways that are not reducible, that there's just no medical expertise about.
All right. I'm going to switch back to some of the questions in the Q&A, and I'm going to pick up a question from another medical student. But before I do that, I'm going to give you a short vignette, which is that, Farr, I'm a primary care doctor. And when I was wrapping up residency, I was pulled aside and said, Lydia, certainly you're not going into primary care. You have far more talent than that. You need to do something more than primary care, which and I know you used to be a primary care doctor, but primary care is, if anything is mere healing, it's about as mere as you get, I think, feeling in the trenches day in and day out. And so one of our medical students asks, could you comment on an overlap between mere healing and an emphasis on primary care? Or perhaps, as we see in many of our academic health centers, a lack of emphasis on primary care.
It has struck me that over the past few decades, we have seen a steady uptick in the proportion of students who aspire to go into subspecialties, and particularly subspecialties that, it seems to me, protect them from the threat of the demands of sick patients on them and of having to have those messy relationships like you have as a primary care physician often. And so I don't think that's all selfishness on the part of students. I think that's also driven by them getting the message that medicine is the provision of healthcare services. And that's kind of the way it works. And you are not to be making judgments about which services are better for a person or not, really. And so in the end, they think, well, if that's the case, why don't I create a bunch of healthcare services efficiently in a way that allows me to spend the rest of my life doing other things I care about and are worthwhile? And so they'll choose a specialty like dermatology or anesthesia. And that's not to impugn the anesthesiologists and dermatologists on this webinar, but there is a movement in that direction. Primary care has been gutted by the systemic things we've talked about, insofar as every aspect of medicine that's either intellectually stimulating or remunerative, and particularly the latter, gets carved out by somebody and pulled into their domain. And so the primary care is kind of left, to a large extent, talking to people about the suffering that won't go away, right? Their chronic pain and their fatigue and their sadness and everything else. It's just part of human experience, and triaging. And it's a problem. I'll just say that. I think I'll just note one little ray of hope to me, I think that's quite compelling, is the people that are innovating in the space of affordable for the masses direct primary care, where they're basically creating mini structures that are insulated to some extent from the system, so that they can orient their time toward attending to the patient and seeking to preserve and restore their health in a way that fits all of who the patient is, their vocation, and everything else. I have watched this in a few colleagues locally, and it kind of honestly brings me to tears to see the difference it makes, that structure. So that gives me a little hope, but I think you need something like that to really, for primary care to flourish.
Thank you. So maybe we'll do two more sort of rounds of questions, maybe a little more critique, and then hopefully end on you're gonna just nail it for us and give us hope, Farr. But there are a couple of different questions relating to perhaps slightly critical of some kind of idealized view of medicine, right? So actually, one person writes, the history of medicine hasn't been healing for all. Poor, marginalized, enslaved patients were specifically harmed by medicine, which I would say demoralized medicine long before the medical education community started to pay any attention to it. And then there are other concerns about truth-telling, which you had commented on. Truth-telling has not always been at the center of the role of healers. Patients and families wanted the truth of diagnoses and prognoses to be disclosed, as well as alternatives. But there has also been a time where that didn't take place in medicine. So just different critiques of, what do you call it? It feels like you're calling us back to something, but
yeah, like nostalgia.
Exactly.
I'm, yeah. So I am nostalgic for some parts of what has been lost, and specifically for losing the idea that medicine is for the patient's health. I'm nostalgic for that. I'm not nostalgic, but if you, the problem with, it seems to me, or a huge problem with those practices of medicine that, for example, gave here in North Carolina, would not, Black patients couldn't get admitted to hospitals unless there happened to be a bed available in a focused, narrow set of beds, even if beds were available on the white wards. Those problems can be described, it seems to me, as problems of not attending to people who are sick in a way that prescinds from the consideration of all their other characteristics. So it's a failure of the justice that is specific to medicine, in addition to the failure of other kinds of justice. And that, so I'm not thinking we should go back to all the corruptions that were in the past. Thankfully, we've moved past some of those, but it is to go back, or is at least to go ahead from the current corruption of reducing medicine to an amoral practice of providing healthcare services. Likewise, in terms of giving information, again, the idea, this is part of the response to Alan, it is not to suggest that physicians have a new authority to act on patients without full, candid disclosure of what they're doing and what the patient faces. It's just to say that when they're going to act on a patient, or when a patient seeks their assistance, I think they reasonably can have as their focus the patient's health, not just whatever the patient thinks might be conducive to their well-being.
Thank you, Farr. I'm going to squeeze in two more questions. Actually,
Sure.
One from the group here, which it gets at how to train students when healing is no longer possible. So do you take a broader definition of healing than curing? If we're training them to be mere healers, but healing is not possible, then what are we left with?
Yeah. So as you said, I'm a palliative medicine physician. So I better have a vision of healing that's more than curing. I could talk about this for longer than anybody wants to listen, but I think it's striking that most people, when they think of hospice, let's say, and palliative medicine, they think, well, how can you talk all this talk about medicine being committed to the patient's health and you practice palliative medicine? I mean, that's not healing. I think that's not true, actually, that palliative medicine, properly understood, and in fact, this understanding is essential to preserving palliative medicine from the kinds of grave ethical errors to which it's always going to be prone, namely getting rid of suffering by getting rid of the sufferer, is to understand that palliative medicine is a part of medicine. And that what we do in palliative medicine, we're practicing it well, is even though we can never say about our patients, again, that they're healthy, we still attend to those dimensions of health that remain and that can be preserved and restored. So health, we can't get rid of the cancer, but we can help people move their bowels, not vomit, be able to sit still without being in racking pain, being able to sleep reasonably appropriate times and reasonably appropriate amounts, reasonably healthy amounts, and so on. And that is a real contribution to the patient's health. That, I think, is in a really palpable, tangible way, clearly consistent with, and even, right at the heart of what healing is about.
So our last question is from a first-year medical student, and I'm going to couple it with a question from one of our junior faculty. So from what this student has experienced and witnessed so far, which is only a few months, I suppose, medical education as it stands seems to be structured to weed out those who might be well suited to be mere healers, those who are empathic and sensitive, through this model focused on perfectionism and amassing as much factual information as possible. How do we stay the course right now in the current system in order to work towards a medical training that is characterized by mere healing? And one of our junior faculty members asks, what small steps can we take right now to further your vision? So I think those two go together.
So I'll start with the small steps. I think you can encourage students to ask themselves, what is medicine for? You know, you have these threads in medical education. I think you call them threads at Columbia. Different people call them different things, but these times where you're not just doing the science and you're not just on the wards, but you're thinking about what you're doing. And in those contexts, I would encourage you to set apart time to ask students, what are we pursuing when we're doing this? What do you think medicine is for? How is this action that we're talking about, or this characteristic that we're talking about, or this habit that we're talking about, essential to, or in conflict with, or at odds with what it means to be a good physician? And get students to ask themselves, what is medicine for? What does health and healing require? Just to ask that question will be radically different for most students. I've talked to thousands of students over the years. Very few have ever been asked in their medical training what medicine is for, what they think medicine is for, much less what do they think health entails and requires. So that's a step you can take. And with respect to the students' concern, that's a difficult challenge. The perfectionism, the amassing a lot of information. I'll just say personally, maybe this is my curmudgeonly side coming out. I don't think the answer is to make everything pass fail, which has been kind of one of the big answers that people take into this to bring down the pressure. I think it's something like reminding people that, hey, we're all in this together, and remember the goal of this is to be as prepared as possible to attend well to people who are sick, not just to perform. And then I guess reflect in our grading and our rewarding and so on, that when we see students showing up and really doing that with energy and conscientiousness, that they're praised for it and they're recognized for practicing the mere healing that we say we want them to learn.
Farr, thank you so much, Dr. Curlin. Thank you so much for this talk tonight, for giving us so much to think about, and for the encouragement for our students and medical educators to think about what medicine is for and to focus on the patient, because that's why ultimately we're here. So thank you so much, and thanks to everyone who joined us. Have a good night.
Thank you.